Serotonin is my neurotransmitter of choice, and in this video, I'm going to talk about the relationship between serotonergic systems dysfunction and anorexia nervosa, while further expanding on the neurological perspective for targeting the disease's root cause. Serotonin is a monoamine neurotransmitter that plays a key role in appetite, anxiety, impulse control, and emotional regulation. These are exactly the domains that are disrupted in eating disorders, especially anorexia nervosa. Anorexia nervosa is a serious eating disorder characterized by persistent food restriction, intense fear of weight gain, and a distorted body image, leading to significantly low body weight. It is often treated as a psychological illness with therapy, nutritional rehab, and behavioral strategies. While these treatments are crucial, relapse rates remain high with mortality rates that surpass all other psychiatric disorders. So today I want to ask, what if we're not treating the root cause? What if the core issue is neurological? Recent researches show that serotonin signaling is altered in the brains of anorexia patients both during illness and after recovery. So instead of just treating the thoughts and behaviors, we might change our perspective and ask, what if we treated the neurotransmitter system itself? Before we dive deeper into how serotonin dysfunction plays a role in anorexia, let's quickly walk through how serotonin works in the brain. It begins with tryptophan, which is converted into serotonin by tryptophan hydroxylase. Serotonin is then stored into the synaptic vesicles by monoamine transporter 2. When it is released from the presynaptic neuron into the synaptic cleft, it binds to serotonin receptors, which are classified into different subtypes, including 5-HT1A and 5-HT2A, that influence mood, anxiety, and behavior. Finally, serotonin is removed from the synaptic cleft through a reuptake facilitated by serotonin transporter SCRT and degradation by enzymes like monoamine oxidase. Numerous PET studies and CSF analysis show persistent serotonergic abnormalities in anorexia patients even after recovery, suggesting a trait-like dysfunction, not just a consequence of malnutrition. In anorexia nervosa, research shows that even after recovery, patients often have increased serotonin receptor binding, especially at 5-HT1A and 5-HT2A. These receptors are found in brain regions that regulate mood, anxiety, and decision-making. This dysregulation may explain the perfectionism, rigidity, and persistent anxiety observed in anorexia, not as learned behavior, but as traits tied to neurochemistry. Furthermore, starvation reduces tryptophan, the amino acid needed to produce serotonin. This drop may temporarily lower anxiety, making the act of not eating feel biologically rewarding. This forms a vicious cycle. Food restriction calms the brain, so the brain learns to fear food. This suggests that serotonergic dysfunction is not just a side effect, and it may be central to the pathology of anorexia. Understanding serotonin's role in anorexia opens door to pharmacological interventions that go beyond symptom control. Firstly, SSRI, or selective serotonin reuptake inhibitors, which work by blocking the serotonin transporter, prevent the reuptake of serotonin into the presynaptic neuron. This increases serotonin availability in the synaptic cleft, enhancing its effect on postsynaptic receptors. In the context of anorexia, SSRI have shown some benefit, particularly in reducing anxiety and depressive symptoms and in preventing relapse after weight has been restored. Second, SNRI, or serotonin norepinephrine reuptake inhibitors, inhibits the reuptake of both serotonin and norepinephrine. This dual action influences mood, arousal, and pain perception. While SNRIs are less commonly used in anorexia specifically, they are more often prescribed in cases of bulimia nervosa, another case of eating disorder, where emotional dysregulation and binge pulse cycles are more prominent. Another strategy is to block monoamine oxidase, the enzyme that breaks down serotonin, dopamine, and norepinephrine in the brain. Drugs like phenelzyne act by preserving serotonin levels, potentially offering anxiolytic and antidepressant effects. However, these medications come with significant dietary restrictions due to risk of hypertensive crisis from theramine-rich foods. This makes them risky in underweight patients who often already have fragile cardiovascular status and inconsistent food intake, limiting their use in anorexia. Finally, a promising line of research involves atypical antipsychotics, especially olanzapine, which antagonizes 5-HT2A receptors and dopamine D2 receptors. In several clinical trials, it has been shown to reduce obsessive thoughts related to food and body image, decrease anxiety and rigid thinking, and even promote modest weight gain, especially in resistant cases. Unlike typical antipsychotics, it carries lower risk of extrapyramidal symptoms, and its serotonin modulating effect makes it especially suited to the neurochemical profile seen in anorexia. Targeting neurotransmitter dysfunction, especially in the serotonin system, may help us move beyond symptom management and start treating the neurological roots of anorexia. This innovating new perspective is important because by targeting neurotransmitter imbalances, we're not just suppressing symptoms. We are addressing the root cause in brain's biology and treating the underlying pathology, not just behaviors.